thanks for coming along to the meeting today, sponsored by Apellis, where we're going. Let's see if I can advance these slides. We've got, really today about macular atrophy, geographic atrophy in age-related macular degeneration. And because as you might have heard, there's some results coming out about the clinical trials that we've been conducting for the last years. And it's a time to really improve our understanding about geographic atrophy, the early signs, the biomarkers, the differentiation in the people, such as we've learnt over the last years for neovascular AMD. So today, I'm just got the lucky job of chairing and helping direct your questions to our panel and our presenters today. So we've got experts, Derek Chan from Sydney, Robin Geimer from Melbourne, and Hemel Mehta, also from Sydney, all of whom have been involved in much of the developing work in macular atrophy and clinical trials. There we go. Going the wrong way. Oh, thanks. I'm not quite sure why that happened there. Let me see if I can do this one. Aha. This is me, welcome address. Here's our little meeting agenda. So Derek's going to be talking about the best practices for diagnosing GA and particularly what biomarkers we've got for progressing. It's going to become really important to understand which people are at risk and what we expect from our patients rather than just lumping them all, oh, you've got dry AMD. And then we've got Professor Robin Geimer talking about what we've learnt from the current clinical trials. Next, Hemel Mehta will turn what we've learned from some of the real-world data for the treatment of GA and how we can prepare for the future landscape. And then there will be time for some panel discussions, and we'll invite, of course, questions from you on the floor. So here are our speakers. I think they're all pretty well known to yourselves. Now, this is just some background and disclaimers. And yes, I think you can all read that there, that we adhere to the Medicine's Code of Conduct. So this is about the panel discussions. Now, you will just raise your hand and there will be some microphones coming around. And there'll also be some polling where I've just discovered myself inside our little app for the Ransco. If you choose the session for your timetable and go down to the bottom, that's where you can find the polling questions. It's taken me till Monday to work that out, but that's how it is. So let's just try a poll. How often in the current state are you following up your people with geographic atrophy? Let me see if I can do it. No, I don't know how we get the results up here, but there must be some way. That's my canny audio-visual people going to help show us some poll results. See if anyone's awake. Huh. Seems to have gone back to the main presenter. Do we? Are they? Oh, we can see it on our little thing here, 6 to 12 months. Yeah, so a little smattering there. Most people 6 to 12 months and a quarter each, 1 to 2 yearly, and some people just send them back to their optometrist. Right. Can we have the things back? Oh, there we are. Thank you very much. You've got that on, worked that out. Fantastic. Let's go to the next poll question. I've got it up here. You're going to span back and forward audio-visual gurus. Thank you. We haven't got the question up yet. Can we put the question onto the panel here? Thank you. Thank you. So, and this is about what imaging options do you currently use to diagnose? This will be the topic of Derek's talk in particular. So please, you can select a few of them there if you like. Which ones that you choose. And we've got an immediate response coming in. So most people are using, everyone seems to be using OCT, quite a lot of people using colour pretty routinely. and autofluorescence. That's great. Autofluorescence, of course, as we'll be hearing, is really important modality coming into importance when we're managing people with atrophy. Great, so let's go back to the slides, thanks. And with that, I'm going to go and sit down, and we've got the speakers coming up. Derek Chan, thanks very much, from Sydney. He's going to be talking about diagnosis. Use the computer.
Use the computer. All right.
Yeah, I find that better.
Okay.
Over there with the button.
So I'm going to just give you a little bit of information about how we're going to try to figure out which of these patients are going to progress. So the first place I want to start is patients often ask, do I have dry macular degeneration? This isn't a particularly great term to use because it has such a broad range. We could be talking about someone with intermediate AMD, with a good prognosis, to someone with geographic atrophy who's likely to have very significant visual impairment. The one thing they have in common, though, is that we haven't had any treatment for them. The treatment's been the same, and so we've lumped them all together. But that's changing now, and Robin's going to talk more a little bit about that in a moment. And it's important to be able to distinguish which of those patients have got a greater prognosis and which ones are going to progress and have poor vision. The original classification is based on colour fundus photography, and these are normal, so we won't spend much time on it other than to say you're allowed to have a small drusen less than half the width of the vein and be considered normal, while early AMD has drusen that size up to the size of the vein as it crosses the disc margin. Intermediate drusen, larger than that, associated with or without some pigment changes that can be either hypo or hyperpigmented. And late AMD, it can be either neovascular or atrophic or both. And it's important to remember that the symptoms of geographic atrophy lead to impaired reading and facial recognition, as well as difficulties with dark adaptation and contrast sensitivity. And this doesn't always show up on just visual acuity testing. And it accounts for a reasonably large portion of legal blindness associated with macular degeneration, about 20%. And we always think of geographic atrophy as a slowly progressive thing, but that's not actually terribly true. So this data came from a UK study that looked at a cohort of people who've been diagnosed with bilateral GA. And of those patients who still had vision good enough to drive, 2/3 of them lost their ability to drive within 1.6 years. And 40% of them lost 2 lines of vision over 2.5 years. And so the impact of this on patients who, once they've got some geographic atrophy, tends to be quite quick. So how do we find those patients? How do we know which of those patients are particularly high risk? So as you all do, there's OCTs, fundus autofluorescence, colour photography, and near-infrared imaging. Other modalities can be used, but really they're all non-invasive, and that's why we all do them. The extra bits of information you get from fundus autofluorescence is it tells you about the RPE. So it tells you which are the areas that are sick, which ones are more likely to have areas of progression, so they're hyper-autofluorescent, but also tells you which areas have already died away and there's RPE missing. And so they are the hypofluorescent, those darker areas. You can see that they're quite dark, usually about the same darkness as the veins and the optic disc. This is a sort of key parameter which we use in the clinical trials to tell us the size of the lesions. This is the way lesions are measured in trials. OCTs, though, give us the not just a particular area, but tell us about the structure. It tells us what's going on in those areas. And there's been a classification based on the classification of atrophy meetings, which were published over the last decade or so. And the key sort of definition of macular atrophy, and you notice I use macular atrophy as opposed to geographic atrophy. So macular atrophy is any type of atrophy in the macula, and it can be associated with or without neovascularization, or geographic atrophy is a term we reserve solely for eyes that don't have geographic atrophy, don't have neovascularization in that area. So C-RORA, or complete RPE and outer retinal atrophy, is a zone of choroidal hypertransmission. So we see that's that signal transmission at the bottom here, as well as attenuation or loss of the RPE overlying that, and the photoreceptors sunken down and degenerated in that area. And there needs to be no other reason why those patients have that loss of RPE, like an RPE tear. Incomplete RPE and outer retinal atrophy, or iRORA, is simply a smaller lesion than that. So it's the same features. You need to have all three features to meet this criteria, but it's just smaller than 250 microns. Of note, there are some patients who don't meet all of those criteria, but are at quite significant increased risk of developing significant geographic atrophy. And so that we call nascent geographic atrophy. And that there are two sort of key features in that. There is subsidence of the outer plexiform layer and inner nuclear layer. So we see that here. And associated with that, we see loss of the ellipsoid zone and the external limiting membrane. And we can also see, so that's there and there. And we can also see increased signal hypertransmission, but it's not necessary to have that. The second finding, and you can have one or the other, unlike C-RORA and iRORA, where you need to have all of the features, you only need to have one of them. You can have this hyporeflective wedge, which is this little black bit here. And that's often associated with the same subsidence. So we see that subsidence here, as well as regression of the drusen and the signal hypertransmission. Right. And that's really significant because there's about a 78 times higher risk of progression to geographic atrophy in this group of patients. So what are some of the biomarkers? So if we take a patient who has pure intermediate AMD that doesn't have any evidence of geographic atrophy, there are a few key factors. So the characteristics about the drusen and the pigmentary changes are very key, and subretinal drusenoid deposits. The ARED study published a simplified severity scale, and this is very easy to do in your own clinical practice. It tells us what you can do is look at whether there's the presence of large drusen and pigmentary changes in each eye, and get a point for each of those. And so the maximum point you can score is 4. If you have no large drusen, you can also get a point if you have bilateral intermediate drusen. And if you have 0 points, your risk of progression over the next 5 years is very low. 1 point is still not very high. But once you get to 2 points, your risk is significant, about 12%. And the way I remember from here is that you just double the risk. So 3 is 25 and 4 is 50%. Reticular pseudodrusen, a feature that has become more evident in the literature recently. It shows the areas of, these are harder to see on colour fundus photography, so they weren't included in those earlier studies which were mainly based on that. But if you have a look at the near-infrared image up here, we see there's this little fine black dots. And we also see them on the autofluorescence image. And this is what reticular pseudodrusen look like. They're blocking the normal melanin from the RPE and the normal RPE signal from coming through, and that's why they appear dark. They appear as these small sawtooth or lesions in the subretinal space. And they're associated with a significant increased risk of progression of both neovascular AMD, but also geographic atrophy. There have been approaches to use deep learning to take those, study some of those patients in the AREDS2 study and then bring that information back to the ARED study. And so the ARED study published this paper this year, which showed the association between reticular pseudodrusen and the rate of progression to late AMD. The key things from this is that if you look at the yellow lines at the bottom, so the 0 to 1 risk factor group, they whether or not you have reticular pseudodrusen, they still don't progress very much. If you have a high risk, if you have all 4 risk factors your risk of progression to geographic atrophy is increased significantly, as with all the other intermediate levels. For neovascular AMD, though, your risk rises to the same level that you would get if you had all 4 risk factors, but it didn't really matter. Once you got to 4 risk factors, you were no higher risk. So the people who really were worse off if they had reticular pseudodrusen had the 2 risk factors. They've gone from this bottom dotted line, here up to join the rest of the group over there. Right. So the other things that we can see is the RPE changes. You see intraretinal hyperreflective foci, and this shows a series of OCTs taken a year. This is going back a baseline 1 year and 2 years. You see you get these pigment clumps here that then migrate into the retina. And that's been associated with about a 5-fold increase in risk of progression. These retina maps show that you start out with only a couple of little spots, and then gradually you add more spots as time goes by. A pigment epithelial detachment. So these drusen with pigment epithelial detachments, this is pretty high risk for progression. They've got the large amount of drusen. They've also got pigment migration within it. And the risk of progression there progressively over 5 years is very high too for both geographic atrophy and neovascularization. So some of the other biomarkers that have been reported, so we sort of talked about high drusen volume or the hyperreflective foci already. But the other sort of features is this hyperreflective drusen core, so this darker area within. There's some papers that talk about this and say that this increases your risk of progression, and there's also been other groups that have published that have said that there isn't a significant increase in risk. The last is this thin double layer sign. So you can see at the bottom here, there's this dark line in between the RPE and Brooks membrane. And so that forms that thin double layer sign there. And this is thought to be a basal laminar deposit and is associated with an increased risk. This was published about a month ago. It's in still a preprint, but it shows a retrospective case looking at intermediate AMD patients in the US that didn't have any evidence of geographic atrophy or choroidal neovascularization, and followed them for 2 years. And these features were significantly associated with the development of geographic atrophy. Actually going back to that, the last point is that the fellow eye is really important too. So the fellow eye increases your risk of progression of developing geographic atrophy in the study eye. But it also it has important impacts. Once you've got a patient who's got geographic atrophy, those patients tend to progress more quickly. And if they've got a fast progressing eye on the other side, they tend to be a fast progressor in this eye too. We also have certain features about lesions. So once you've got some geographic atrophy, you can look at the geographic atrophy lesion. It will tell you what the rate of progression is to some extent. So small lesions progress more slowly. The larger the lesion is, the greater the rate of progression because there's greater area that can be affected. Multifocal lesions tend to progress more quickly, and extrafoveal lesions progress more quickly. The foveal lesions tend to have more visual impact initially though. Fundus autofluorescence is an important way of determining some of the differences between these groups. So patients who have, for example, an area of focal atrophy like this tend to have a very slow rate of progression, while these diffuse patterns, in particular this diffuse trickling pattern, tends to progress very quickly. The diffuse trickling pattern looks a little bit different from the others, and that helps to identify the worst patients. So you might notice that the area of atrophy isn't as dark in these pictures as some of the others. And so the atrophy is a bit grayer, and they have this coalescent lobular pattern. So you see these little lobules form at the edge and then join onto the main lesion. And they also have that splitting of RPE and Brooks membrane, so that thin double layer sign. So in summary, atrophic lesions have a tendency to irreversibly progress. They have about 2.5 years from when they first appear to causing foveal loss, with extrafoveal lesions progressing quicker. So we're going to move on to a case study. So this is a 57-year-old lady. She was a smoker for many years, had a family history of AMD, and she came for a diabetic eye check, but she's got lots of features of intermediate AMD. So she has all of her drusen, a drusenoid pigment epithelial detachment, and in one eye she has some hyperreflective foci. This is her near-infrared imaging. We haven't talked much about that so far, but you can see that there is a little central light there that is just a reflection, but next to it, you see on this side, there's this little white spots, and these are the pigments. So the melanin absorbs and reflects the infrared image, so we see that appear white. So there's a polling question for you. This patient has intermediate AMD. Based on their OCT images, how many risk factors do you think they have, and what do you think their 5-year risk of progression based on the AREDS study? So, a moment to have a look. So we might see what the results are. So people said C, they have 4 risk factors. So they have, we can go back to the, we've still got some more people coming in. So most people said there's 4 risk factors, but there is no pigment migration in the right eye. So they predominantly have 3 risk factors, about 25% risk of progression. The problem with the 25% is that it's not quite the whole story. This patient doesn't have reticular pseudodrusen, but they have lots of other risk factors. They are young, which actually lowers their risk of progression. If you're younger, the rate of progression is slower, but because they live for more years, they're more likely to have visual impairment in their life. It doesn't take into account that they're a smoker and their family history as well. So this is 2 years later, and they're still fairly similar. They still have the pigment epithelial detachment's gotten larger. And this is 5 years after that. So over this 5 years, they've now developed geographic atrophy. That's easiest seen on the autofluorescence image. So we can see a dark spot here, but we also see in the other eye, even though it's not foveal, that they have developed multifocal little spots of atrophy as well. We can see the pigment migration here on the near-infrared image, and we see the features of C-RORA on the OCT scan. The other thing to say is that the drusen, those very large drusen, have all regressed in this eye. And so this is now, instead of 5 years later, only 3 years later. And you can see that the area of atrophy has gotten a lot bigger. The visual acuity has really dropped away. And the areas of atrophy, if we were to jump back and forwards between the two, have grown substantially in terms of the area of involvement. Okay. So this patient has a high risk of progression on a combination of factors: their family history, smoking, large drusen volume, having those hyperreflective foci, and a diffuse autofluorescence pattern. The real question is, what's going to be the time to intervene and which eye should be treated? And we'll come to that a bit later in the talk. So in summary, multimodal imaging helps us to define the areas of geographic atrophy. The classification allows us to stratify those patients. There are lots of little features that you can look for on the OCT, such as the thin double layer sign, the areas of atrophy, the distance from the fovea, the fundus autofluorescence pattern, such as the diffuse trickling pattern, and the presence of reticular pseudodrusen and pigmentary changes. An early detection of those patients will allow us to make a more timely intervention in these patients to slow the disease and hopefully save some vision. So Robin's going to come up and tell us a little bit more about the clinical trials in geographic atrophy. Thank you.
Thanks, Derek. Thanks very much for inviting me to be part of this important session, particularly as we inch our way towards our first treatment for geographic atrophy. So it's a great pleasure to present to you what we've learned from the clinical trials in geographic atrophy. Here are my disclosures. So you can see from this slide, there's been a lot of activity over many years trying to find a treatment for geographic atrophy, and this really just highlights some of the activity looking to try and dampen down the activity of the complement pathway. And so just to highlight a few events here, you can see that not all of the attempts have been successful. For example, very highly publicised lampalizumab studies done by Roche looking at blocking factor D was perhaps the first attempt to block the complement pathway, and it really failed to show any benefit and was discontinued. But as you can see in 2017, pegcetacoplan, which is the drug we're talking about today, finished its phase 2 study called FILLY. And you can see that it's actually leading the way forward in that it is sort of first to reach its phase 3 studies, of which they presented just a month or so ago the 24-month results of the secondary outcomes, and the primary outcome, which was at 12 months, was presented in 2021. But you can also see that there are a couple of others that are not too far behind, particularly the GATHER studies, which are blocking another molecule, the C5 molecule, are still in the middle of their phase 3 study called GATHER2. So there's quite an active trial area at the moment, which is fantastic. So let's turn our attention to pegcetacoplan, which binds C3 and C3b here. And we're all getting used to this complement picture, I'm sure, by now. And basically, the end goal is to reduce complement activity, as that is thought to be involved in AMD development and definitely progression. And by blocking complement pathway, you end up blocking this MAC attack complex, which leads to cell lysis and death of cells. So ultimately, what we're trying to do is keep those retinal cells alive. So just to remind you, if you're not fully aware of what the phase 3 Oaks and Derby studies were, I'll go through the study design. So basically, over 1,200 patients were recruited with geographic atrophy secondary to AMD. It was an international 2 studies, phase 3, and patients were randomized either to pegcetacoplan every month as an intravitreal injection, or every other month as an intravitreal injection, or sham monthly, or sham every other month. The primary endpoint was looking at this, what Derek showed us, these geographic atrophy lesions, the geographic atrophy as defined on fundus autofluorescence, looking at the change in total area from baseline to 12 months. Interestingly, you can see that the 12-month primary outcome had nothing to do with vision, which is what we're used to looking at in our wet AMD trials. But as we all know, vision is not a good indicator of progression of geographic atrophy. So the primary endpoint, for the first time in AMD trials, indeed, was actually an anatomical endpoint of rate of growth. But the secondary endpoints, of course, are very important, and they are all the functional endpoints. And they were looked at 24 months, and things like visual acuity, but also looking at low luminance visual acuity, different reading indices, and particularly microperimetry, which is where you look at retinal sensitivity. And then the GALE study is a 3-year open label extension study, which will give us much more long-term data. And so perhaps of all the GA trials, this is most inclusive because you're allowed to have GA lesions under the fovea or extrafoveal lesions. You could be multifocal, unifocal. There's a wide range of size of the initial lesions. But you did have to have this presence of this perilesional hyperautofluorescence, because that's thought to be a sign of high rate of progression. So most studies will require you to have some of that autofluorescent pattern. Key exclusion criteria were we don't want diseases mimicking geographic atrophy, and unfortunately it's often hard to tell the difference, particularly inherited diseases like Stargardt's, and often the fundus autofluorescence will help you differentiate those two. But particularly in this study, you were allowed to have CMV in the other eye, and that therefore potentially increased the risk of getting CMV in the eye that is the study eye. So what did the results show? So these are the 24-month results combined from those 2 studies. And here the monthly dosing is in orange, the every other month is in blue, and that compares to this sort of lighter orange, which is the sham group, which usually is grey in all the other presentations. But today we have it as light orange. And as you can see that the slope diverges as time goes by, and there is a a statistically significant difference in that rate of growth at the end of the 2 years in both studies and in both treatment arms. This is when they separate the non-foveal to the foveal lesions. Hopefully you can appreciate those non-foveal or extrafoveal lesions. There's actually a bigger effect, that they show a bigger difference in that growth rate compared to the subfoveal lesions. Also, what's interesting is if you break down the change in growth over each 6-monthly period, you see a bigger effect the further you go. And you can imagine that early on, you probably can't save those cells that are on their way out. They're on death's door. And so those early ones, there's not much, you have to wait a bit longer than 6 months to start to see an effect. And so very nicely, you can see with every subsequent 6 months, there's a bigger difference between the two groups. So that was the anatomical change. There was a statistically significant difference in slowing the rate of growth of cell death. So you would think that that's fantastic, but then when you're trying to back that up with some functional benefit, we see at 2 years, there's actually no difference in the best corrected visual acuity. Again, remembering that in geographic atrophy, we know that visual acuity is not the best measure, as in GA in particular, the lesions often start extrafoveally. And so it takes a while for them to actually impact on best corrected visual acuity. And we see this all the time in the clinic. People read all the way down the chart, but they certainly have symptoms. So in a post hoc analysis, we've been looking to see, well, what can we find here? Surely there is something that you can measure that's different, given that change in growth rate. And so everyone may not be so familiar with microperimetry, but in microperimetry, you put mini spots on the retina and you ask people to push the button when they see the light, and the black in the middle is dense scotoma. You cannot see the light. So as you can imagine, in the middle of a GA lesion, totally not seeing it. But in the primary analysis, in the analysis, the main analysis is averaged all those spots, and you can see really not much use averaging those spots that are green, that are pretty healthy, away from the lesion. It would be much better to concentrate on what's happening around the lesion. So the idea was to just look, well, what about those spots that are within 250 microns of the border of the GA lesion? What if you just counted those spots there? Could you see a difference? And so that seems a logical thing to do. It was a post hoc analysis. And now for the first time, we do see a difference. So if you look towards the end, the last 6 months, you start to see this divergence, and now sham is in grey. You will see that they continue to decline in terms of the mean sensitivity, but only counting the spots around the lesion, and the number of scotomatous points, so the number of points that were black that didn't respond, the patient did not respond at all. You're starting to see a difference. And so I'm certain that the longer we look, the more benefits we're going to see in terms of function. Another way that we've been looking at these results is to perhaps use some AI, to get with the game of AI. And so Ursula Schmidt-Erfurt is well recognised as an AI guru over in Vienna, and she'd been able to look at the FILLY data, which is the phase 2 data, but then she's also now looking at the phase 3 studies. And what she's able to do is segment the different layers in the retina. So this is looking at the thickness of the photoreceptor layer on your left, and on your right, RPE loss. And so from this, remembering it's AI, there seems to be a very marked difference in the thickness of the photoreceptors with the treatment versus the sham. So again, it's an anatomical change. The photoreceptor loss is quite striking compared to the RPE loss, but still both are very significantly different. And this is the OAK study, and very similar in the Derby study. So sort of a validation that what we see when we measure GA growth, we are saving those cells that are remaining. They're staying more healthy. So fantastic. And if you haven't been listening, look up now, because this is fantastic. So this is a a video of the change between the study eye, which is on your left, and the fellow eye on your right. And this is looking at the green, which is the photoreceptor loss, and the orangey color, which is the RPE loss. So if I play this, just look at the growth, the study eye versus the fellow eye. So sort of the study eye just seems to sort of halt, remembering initially growing but then just not doing much compared to the fellow eye. Cool. So a very nice way to show the difference. So if we just go back to the studies and look to see how they were designed, we can see here that even despite COVID, there was really good completion in the Oaks and Derby of the patients in the study. And in terms of who got their injections, a large number, 80 to 90% of the injections that were supposed to be given were given, which is a great outcome from this study. And turning to safety, there really was no safety signals. Very early on in the study, there were some inflammatory issues, and it was noted that there was an impurity in the way the drug was formulated. And so the study was stopped. They went away and reformulated their drug and then continued on with far less episodes of inflammation. But the data includes those people that were in those original impurity inflammatory events. But we see here that there are more treatment emergent adverse events in the treated groups versus sham, which is what you would expect, but really quite low numbers of endophthalmitis. And what we're interested in really is this inflammatory adverse event. And looking more closely at inflammation and endophthalmitis, and perhaps paying attention to the 24-month results, we see the rate of intraocular inflammation is 0.24% per injection, slightly less if you exclude those ones that had the impurity. Most of the events were mild or moderate. 77% of those people who had inflammation resumed the study drug. There were no patients that discontinued as a result of inflammation. And importantly, there were no reports of occlusive vasculitis or retinitis. And the endophthalmitis rate was about 1 in 3,000, which is pretty much what we expect in studies using intravitreal injections. Interestingly, let's turn our attention now to exudative AMD or neovascular AMD. What has been noted is that there is an increased rate in the treatment arms versus the sham. And so if you look at the monthly rate, it's about 12% at 24 months. Every other month is half that, about 6, and the sham is half that, about 3. If you look at those that are confirmed in the reading centre, slightly less, but still different between the treatment and the sham. But the way I look at this is if the drug is working and saving RPE, it's still perhaps not 100% healthy, but it's still functional. It's the thing that's making VEGF. So in fact, it would be very odd not to see an increased rate of CMV if you were actually truly having an effect of saving more RPE that's there to make VEGF. Most of the CMV were occult. People continued in the study. They received their pegcetacoplan and then were given an anti-VEGF therapy at the discretion of the investigator. And no patient discontinued as a result of having exudative AMD. So here's just a nice case study to end with. This patient has a slowly growing patch of atrophy. There's really quite subtle differences in those images over 12 months. However, the vision changed 10 letters with that subtle change, likely because it's now starting to encroach on the fovea. And you can see that here, baseline on your left, 12 months on your right. That little star is the preferred retinal locus where the patient's looking, and at 12 months, perhaps it's getting a little closer. You can see that those dense scotoma points are increasing from baseline to 12 months. And this is just a different way to represent what we see. If you just pay attention to the graph on your right, the red are and the yellow are the patches that have decreased in that 12 months. So significant numbers have dropped, large number of decibels, and the vision in this case dropped 10 letters. The matching up the microperimetry with the OCT, I actually can't really explain such a profound drop when the OCT looks very similar. You can see there's a patch there that was 19 decibels that went to 0, and it looks pretty similar to me. But there you go. Maybe you can't function drops before the anatomy changes in that case. And this is just another example showing the quite fast growth of the atrophic lesions in this case. And the vision, however, stays pretty stable in that first year and a half. So even though we can all see that something that stopped that growth would be a good idea, regulatory authorities will probably say, well, did the patient benefit? Where is the functional difference? And it's not until another couple of years that there's a dramatic drop in visual acuity. So it's really just to bring home the point that visual acuity really isn't a great way to measure efficacy of treatments. So in summary then, pegcetacoplan slows geographic progression in both the every other month and the monthly dosing, and the effects seem to be greater over time. In a post-hoc analysis, we do start to see some functional benefit from those perilesional microperimetry results. We see preservation of retinal sensitivity. Pegcetacoplan was well tolerated in people with geographic atrophy. The safety profile is consistent with other intravitreal injections. And this now forms a very large data set of geographic atrophy. Both the 2 phase 3 studies and the FILLY phase 2 studies will be reviewed by the FDA. We're expecting a result very shortly on what they think. And then shortly after that, the Europeans will get their opportunity to have a look at the submission. So I think we have a polling question. If we all turn back to our phones, which parameter would you use to define successfully managed geographic atrophy? And you can choose as many of these as you would like. It's a very important question because patients are going to be wanting to know they're having these injections and they're not seeing necessarily a benefit. How are you explaining to them why they're having their injections? So we can see improvement or no change in vision. So at least they haven't lost vision. A no, we're seeing reduction. Oh, C, reduction in rate of lesion growth, and D, reduction in rate of foveal encroachment. Terrific. So at least clinicians can understand the value in stopping cells from dying. Our main challenge is to convince regulatory authorities of the same. And that's where we're at the moment. So I think that is all for me, and I'll hand over to Hemel Mehta to keep going. Thank you.
Thank you, Robin. And essentially, I think it's a pretty exciting time in ophthalmology. We've just seen some very encouraging phase 3 results showing that we can potentially slow down GA progression. We've not been able to do that before. The question, I think, for us now is how do we apply these clinical trial results to our everyday practice? And what I want to talk about here a little bit more is essentially to raise some questions. I don't actually have many of the answers, but I'm hoping that as a community we can think about those questions and formulate the answers over the coming period. So we're going to start off. You've heard the phase 3 data. So over to you. If there was a treatment available, which kind of patients would you be treating? And you can select all that apply. To give some context, there was a prevalent study looking at patients of European descent showing that if you look at patients over the age of 80, over 5% of patients have late-stage AMD. So that's 1 in 20 people over the age of 80. So are we going to treat all of them? Right, so we've got the winner right now being patients who've lost vision in the fellow eye. And look, I think that's that sounds sensible in terms of it's a cohort of patients who would be highly motivated. They've seen what the disease can do in one eye. And we've already seen from the previous data that this is a group that are at high risk of developing sight-threatening disease in the future. Extrafoveal GA seems to be the next most popular factor. And again, we saw in the data there that was a group of more rapid progression. So I feel there are 4 key questions here. Who are we going to treat? And we had a little bit of an insight from that poll there, and we'll try and expand on that. What tests should we be doing? Because I think if we're going to be looking at who we treat, we're probably going to need to try and identify who's going to progress rapidly. And how are we going to identify who are the patients who are going to progress to the extent that they develop geographic atrophy that's going to impair their quality of life. And the only way we're going to know that is if we essentially measure data over different time points and have a combination of structural and functional endpoints. What are we going to do when patients develop concurrent neovascular and atrophic AMD? This is not really something that can be addressed easily within a clinical trial setting, and so we're going to have to collect real-world data to understand that better. And then finally, how do you identify the patients in the community most likely to benefit from these emerging treatments? And pegcetacoplan is the first, but we're actually looking at the trials that Robin described earlier. There's hopefully actually a pipeline of new treatments coming through for these indications. So what type of imaging should we do now? And I would say that probably the most important ones are going to be the fundus autofluorescence, because at the end of the day, that was the area that was the primary outcome of these clinical trials, and OCT imaging, which we widely have access to. There are other imaging modalities that we can consider. We saw very nice pictures that Derek showed us of reticular pseudodrusen on near-infrared image. The image you kind of get for free when you do the OCT on a Heidelberg. And there's been some evidence to show that you get choriocapillary dropout that you can identify on OCT angiography, which may be a predictive factor. Less keen on using invasive tests like fundus fluorescein angiography when there is no suspicion of neovascular AMD. But we can go beyond that, because it's not just about what imaging are you going to do. You've got to say, well, what device are you going to use? So if you're going to do autofluorescence, are you going to be using your Heidelberg machine? Are you going to use your Optos machine? How do these different data points actually correlate with each other? Because, for example, you may have a patient who's had a type of imaging done in the community, maybe by their optometrist. And if you're lucky, they'll have used the same device as you, but there's a good chance they won't have. And even if they did use the same device as you, did they use the same scan protocol? So there's a very nice review that Robin's recently, or editorial that Robin's produced, talking about essentially the scan width, or how finely you do your OCT scans, is an important parameter. And if you use the regular 120 micron spacing that we currently use, ordinarily, we may miss small GA lesions. And then how often do we do these imaging assessments? That, the very first question of the morning was somewhere between 6 and 12 months. And I suspect that's the right answer, but we'll need to determine that as a community. Now, why do we want to collect this imaging data? Because we want to try and identify who are the patients who are progressing most rapidly, and therefore the patients who are most at risk of sight-threatening disease, or disease that's going to reduce their function. Now, the reality is that we're not going to be able to do that manually. We're going to be very reliant on machine learning approaches to help us achieve this. And it's a field that will continue to grow. This is a really nice paper that's in ophthalmology retina, and essentially it measures not only the GA area, but also what direction is the lesion going in, and what's happening to the tissue just adjacent to where the GA lesion is as well. So there's going to be a number of imaging parameters that will hopefully help us in the future. We don't know all of the factors yet, and when you look at the journals, it seems like every second paper is on a new machine learning algorithm that's identified another prognostic factor. So this is going to be a space that evolves. What about, how can you kind of essentially correlate if you have measured a GA area on an OCT or on fundus autofluorescence? And this is a really nice study from the phase 2 Philly data, where they showed that if you have a lesion that's less than 10 millimeters squared, you actually have quite good correlation between OCT measurements and fundus autofluorescence imaging. However, when you get larger lesions, you then start to see a slight bias towards higher GA area measurements with fundus autofluorescence. So what about functional tests? And we saw in the phase 3 data there that although we were seeing improvements structurally, none of the functional tests actually showed a positive outcome there. And I suspect the reason is, and I think as previous speakers have said, is that we probably have to wait longer to start seeing the differences in functional outcomes here. There is an extension of the Oaks and Derby trials called GALE, which goes on for another 3 years. And it'd be really interesting as data comes out with longer follow-up to see whether the functional outputs start, we start seeing them and the meaningful improvements. Now, there's a few functional tests that they used in the trial. There was a concept of low luminance visual acuity. So what that essentially is that you carry out your visual acuity on a normal logMAR chart, but you actually put in a neutral density filter of 2 logMAR units to essentially make the scene dimmer for the patient. And that actually can be a very sensitive way of assessing visual function, and it seems to be more sensitive than this ordinary full luminance best corrected visual acuity. Reading speed, although, as I say, did not show a primary outcome there in the trial, I suspect with longer follow-up it may do. And then again, with microperimetry, we discussed essentially maybe these perilesional areas may be useful. But again, which of these tests are going to be practical in a clinic setting? So I think of microperimetry a little bit like your typical visual field testing. And there are some patients who are very compliant and will give you very helpful data in their management. But it's going to be a lot of patients who are not going to do very well on the microperimetry testing. And I think it's just important that we are careful not to make that a parameter that decides whether somebody can get treatment or not, because you don't want to deny somebody treatment because they can't do a test well. In terms of risk factors for GA progression, low luminance deficit was one of the main factors of functional outcomes. So what that means is that you measure the vision with the low luminance method with the neutral density filter, then you measure it, you actually do the first measurement without the filter there, normal best corrected visual acuity, and then you take the two away from each other, and that gives you the low luminance deficit. And that seemed to be quite a helpful factor for assessing progression. And it may be that this is something we need to start getting used to in our clinics, try and find a neutral density filter and a trial frame. We've discussed this already in terms of the microperimetry data from the phase 3 study. And again, it'll be interesting to see with longer term follow-up whether this gives us more useful functional data. So the third question here is, how do we treat concurrent neovascular and atrophic AMD? 1 year after treatment initiation, the FRB registry identified that about 9.9% of eyes had developed macular atrophy when being treated with anti-VEGF therapy. And 5 years after treatment initiation, that was 41.5%. So this is going to be a common issue, and we don't really have the answer to this question yet. And then, as we've seen in the safety data here, that we're going to see a little bit of new onset exudative AMD. And that seems to be across the complement factor inhibitor trials. that you see a small amount of this developing. And again, how do we deal concurrently managing two diseases there? And because that data is not necessarily available in clinical trials, we'll need high-quality real-world data to inform practice patterns. So we were really pleased, actually, earlier in this meeting to be awarded an Australian Vision Research Primer grant from the RANZCO New South Wales branch to actually help try and address some of these questions. And what we're trying to do with the FRB registry is to take advantage of the very high quality registry fields there and link imaging to that. And we're doing that using interoperability approaches. So luckily, a lot of imaging is DICOM compliant, but we're also using some quite well-established now fast healthcare interoperability resources, or FHIR technology, to allow us to link data across platforms and across visits. And we'll also be hopefully using AI models as a third source of data there to help us improve patient outcomes. This is just to give you a little feel. Those of you familiar with the FRB registry will be familiar with this screen, but wouldn't it be nice if we can actually input a measurement that we think is useful, for example, the GA area, and we can specify the device, the number of slices, and hopefully automatically give you that to help your patient management. So the last question is, how do you identify patients in the community most likely to benefit from emerging treatments? We'll need to work with the opticians closely, and RANZCO will need to take a lead in that, because it's not going to be possible for us to monitor every patient, particularly patients who are quite low risk of developing visual impairment. There'll be advocacy from RANZCO as well as patient support groups. We need to educate our colleagues, particularly optometrists in our referral networks, and then caregivers and patients. And we need to take advantage of data that is currently siloed in different areas. So for example, a patient may have a lot of historic imaging data that's at their optician. And if we can link that to more recent data that we may have in the patient in the clinic, we can then understand disease progression and offer treatment to patient at an earlier stage. So this is just the last slide, really, to show that, and it's courtesy of a colleague of mine, Dr. Ashley Crass, who's ophthalmologist with a bioinformatics background. And it's a really nice diagram of how to think maybe about this with a funnel. So you've got essentially screening campaigns, a lot of kind of community-based education to let people know that there is a treatment available for GA. When I talk to optoms, I'm surprised actually how variable actually the current knowledge base is in terms of these new treatments potentially coming through. Then those patients get referred in, and we try and use data-driven insights to link imaging, perhaps from the optom to our then imaging modalities. We make sure we do all the baseline autofluorescence and OCT. When we're talking about treatment, we can use AI-based techniques to work out which patients will benefit most. And we can also tell patients, project what their functional deficit is going to be in the future. And I think that's going to be really important if we're going to keep patients on treatment and maintain vision. You've got to remember that they're not going to be gaining vision through the course of this. We're slowing down disease progression. And so the education and the way in which we display that information to patients is going to be crucial. So I'm just going to summarize here with the imaging recommendations. So fundus autofluorescence, both because of we need to know how the GA area is developing over time, and we also want to exclude non-GA diseases. So for example, inherited retinal diseases. OCT parameters that we very nicely discussed earlier this morning. And identifying and counseling patients at risk of progression to atrophy. So we need to get really good at picking up intermediate AMD and knowing what that looks like, so that we can then talk to our patients about the likely progression in the future. We're going to hopefully get insights from the FRB registry on how we're going to treat these eyes with concurrent neovascular and atrophic AMD. And all of us need to be advocating, educating, and supporting data-driven insights to identify the patient that will most benefit from future GA treatments. Thank you. I think we're all going to come up to the panel.
Well, I think we're all coming up now. Thanks very much for those great presentations. And we might just move to a question time to see if anyone wants to ask the panel any further information or questions they might have. It's great that you finished with that, Hemel, because quite a few of those things that to start our enhanced understanding are already coming underway, because I know, Robin, you're heading a group to update the referral guidelines for optometrists, and that's going to be really important. You know, the college has had one for AMD for some time, and it's being updated for GA. Yeah.
Terrific. Yeah.
Yep.
But the current guidelines just tell optometrists to perhaps see patients themselves every 6 months. But what we'd like to do is get them that initial referral to someone that has autofluorescence and OCT to get baseline images, so that when they do come back in a year or two, we'll have those images.
Yeah. And for those of you who aren't on the FRB, you know, that's a great way of helping monitor your patients. And we're developing programs on that really are more detailed to monitor, like we've done before, headed by Mark Gillies, of course, to track these people when and if they eventually become to treatment, to get us real-world evidence about what's happening, which helps answer a lot of the questions. So these studies have raised a lot of questions at the moment, and we're really looking forward to answers. And it's really great as well that you mentioned, Hemel, that the studies are going on for another 3 years, so we'll get at least 5 years of data of what happens to these people under treatment, and that's really going to help guide us. You know, so by the time if these drugs become available in our clinic, we should have even more data available about what's going on.
Yeah, that's very good. Any questions from the
If anyone does have a question, just raise your hand and we can mention it. I can see one over there, which is great.
Yeah, what was the effect of multifocal intraocular lenses on the low light visual acuity?
I don't know that data was collected in the original studies.
I mean, does that actually have an effect?
Yeah, we don't have any data about that. Do you have any thoughts about that? It certainly wasn't collected because there's, although information such as the lens status and whether they're pseudophakic, but there was no data collected on the lens because often the investigators don't have that obtainable at the time. So none of the studies, to my knowledge, have ever collected data on what intraocular lens was used. But personally, I try and avoid multifocal lenses in people with AMD because I think they want the sharpest ever. I don't know if anyone else has. Derek, do you have a thought on that?
Yeah, I generally would avoid them as well.
Yes, that's certainly my practice, to avoid them, because I think that can degrade, and these people are going to need everything as sharp as they possibly can. Yeah, I think we can hear you. I can repeat the question if need.
The rate of conversion to wet AMD, I wasn't quite, I'm a bit confused. So did it increase it or decrease it?
Increased it.
Looked like
So,
4 times.
yeah. So in the monthly it was 12%, in the every other month it was about 6.7%, and in the sham it was 3%.
3.6,
Yeah, so
yes.
The increase is and that was my point, I guess, is that that's not unexpected perhaps. If you're saving RPE and photoreceptors, they're perhaps not 100% healthy, but they're being saved, but they're there to produce VEGF. And so I think the two have to go hand in hand. You can't have more RPE with less risk of having the RPE make VEGF. And so it would be odd. I actually don't know how, if you didn't, and interesting, I think you presented the next study also showed a difference. So that's, you're stuck there. But I think that's a very interesting problem, is if you've got a person you're treating with wet AMD and then they've got dry AMD and you've been telling them your retina's looking good because it's dry, And then you have to start another new conversation to say, well, now let's talk about a different sort of dry AMD. So we're going to have to start working out how to do that.
In the study, of course, all the people were allowed to receive treatment and they continued on the study. They weren't exited. So depending on the discretion of the investigating ophthalmologist, and practically all of them were treated, they received both treatments.
And even more tricky is that most of them are occult. So they may not actually be necessarily needing to be treated. And in fact, it may well be where we want to get to is stable, controlled recapitulation of the choriocapillaris giving oxygen, but not exudative, so that they're not causing damage. So if you can get a happy medium where you've got these vessels coming, but you can keep them at bay by perhaps not so regular injections of anti-VEGF, that might actually be a good situation.
Yes. It can, of course, be quite hard to pick up new vessels inside a patient with lots of focal patches. And in fact, about 3/4 of the ones that were identified by the investigator, the reading centre couldn't confirm based on the images, because it is a mixed pattern. But I agree with Robin, we sort of expect to see some increase
And
in
indeed,
these treatments.
if you look at OCT angiography, even in people with drusen, many of them will have non-exudative new vessels. Like such a surprise, who knew that before we had these imaging technologies? So there are people out there with intermediate AMD and geographic atrophy who have doing very well, thank you very much, with vessels there, but they're just not exudative at the moment. There's a question here.
Yeah, go.
Jenny, why do you bother with distance vision? Like if all these people can be 6'12", can hide a myriad of problems from N5 to N12. I think it hides too much of a problem if you're just using distance vision.
You go tell the FDA, that will be good. It's a regular, I mean, they're expecting to see a change in, it's just a traditional way of measuring.
It doesn't mean our data has to be recorded that way.
I think you've raised a really good point, which I think that you brought in as well, Robin, that with GA particularly, that our standard distance vision is only part of the story, and we really need to look in a lot more nuance, and particularly when we're explaining to people, they can understand that because they just find they can't read and they're still 6'6". But yeah, so that's why these GA studies particularly collect a range of functional outcomes, including the low level, the reading speed, all sorts of things. But Robin's right, this is one of the first studies and one of the first indications in macular disease where they've accepted a non-vision endpoint. Because they say, what's the point of a treatment where if you're not impacting the vision? But we know in ones like this, it's going to be some time, but we want to get in before they've lost vision, really. And the patient understands that, or your doctors understand that. Yeah, I agree.
Yeah, some of these patients are very desperate, and you can understand their vision is dropping and things are not working for them. They're seeing 6/12, but can't read. What are the roles of these supplements? You know, what we used to give Macuvision and all that. Is there any role for this, patients at all in this dire situation, bilateral geographic atrophy?
So in the ARID study, they were only ever suggested to be useful in earlier disease. By the time you get to late AMD, there was no benefit in the ARID studies. So even if you were to give them early on, there is no evidence to suggest that they're useful once you're at this point.
Yeah. You got something to say?
And the others that it tends to make a difference more for neovascular AMD than geographic atrophy anyway. So.
I think you're right, though. The patients are certainly desperate when they've lost one eye like this and they're struggling with their vision.
I think that's the group, it's interesting that when we were talking about which patients will we treat, and it was interesting that that was the group that polled the highest, actually, is the patient group who've lost vision in one eye. I think what's very different, perhaps, between the sort of GA population and maybe the neovascular AMD that we're more used to treating is that patients see an initial benefit when we treat the neovascular AMD, and I think that leads to a very strong rate of compliance. And they know that when they miss a treatment, they actually see their vision potentially declining. Whereas with the geographic atrophy treatment, where they're not going to see an improvement, so they have to have some prior knowledge or very good patient education as to why it's important to slow a disease that's not actually necessarily causing significant visual impairment at that point in time. Now, if they've had a significant GA lesion in one eye, they get it 100%, and they'll be chasing you to find the treatment, etc. But if that hasn't been your perspective or experience of it, then why would you know that this is something that you have to treat almost prophylactically? And so I think this is going to be a really important education piece, I think, for us going forward.
I think if I might make a plug here too, because what we're talking about here is the direction of macular research. Well, behind this, Robin, you've been leading a lot of this, is to try and understand really well before they've got the atrophy which patients are coming on. So, Robin, you might like to talk to that.
Yeah, so I guess that was really part of the first presentation, is understanding the very beginnings of atrophy on OCT, which we're not necessarily paying that much attention to, but certainly in community, optometry, ophthalmology, if you can identify people with the very first signs of atrophy, they're the people you start talking to. And they're the ones perhaps you see a bit more often, perhaps 6 monthly rather than not at all, or yearly, just to say there are treatments coming, you come back, so at some point we will start. And then there's a question as to how early you start and how early you're allowed to start or should start. But at least you can start that conversation. Within intermediate AMD, there are a bunch of people who already declare themselves as having the first signs of cell death. So they're the ones you start to have a slightly different conversation.
Yeah, and then we need to learn about how to, the earlier signs here. Like I say, the revolution in neovascular AMD, we really started to understand the details, or we all lumped them together. We're working, even earlier on these studies. So there's a bit of a plea, there's studies on in most of the major centres about people with intermediate AMD, just to collect this sort of data, so we're better poised to understand who's going on. Robin's been working for this on years, but that's another thing that we can do now. For people, they can be staged and get involved in long-term natural history studies as well, which are going to give us the data for the future, aren't they?
So that's right, Jenny. So at the moment, all the studies, you have to start with a patch of geographic atrophy that you can measure, which is why there's a certain size that's required. And then you have to measure the change in rate of growth. But what would be much better is if you had a treatment that you could start earlier. But what are you going to see to put in a high-risk group? So you could imagine you would put in intermediate AMD with starting of atrophy. And so I think Jenny's alluded to, there are some studies starting of intermediate AMD just to learn that natural history that's happening around Australia. So people who do have even intermediate AMD, there may well be trials for them so that we can learn more. And in fact, with Apellis, we're ourselves doing a study to try and work out how best to plot that change in sensitivity. There's got to be better ways that we can actually map the function of change.
That's right. We need better endpoints, as Gary brought out for our studies. Yeah, we have a question over there.
I've got a question about surrounding hyperautofluorescence, which was part of the inclusion study criteria, and which is a sign of progression of itself inherently. And I guess two-part question. Firstly, to what extent do you think this may, if at all, have an impact on selection bias towards those that have progressive GA lesions? And secondly, how is that going to impact real-world practice, and how we're meant to interpret imaging of autofluorescence scans to determine treatment candidacy?
Well, certainly I think when you're conducting a study, in a slowly progressive disease like GA, and you're managing your patient numbers to make the study manageable, a study will always want to enrich people that have a risk of progressing. So all the studies in GA will choose people that are likely to progress, and so hyperautofluorescence is one of those criteria. But one of the points, the allied points in there, is that the importance of autofluorescence is going to really come to the fore. Like, how could we manage neovascular AMD without OCT? It's going to be that how can we manage people with macular atrophy without autofluorescence imaging? It's going to become more and more important. That's one thing that we as clinicians start to get ourselves prepared. Those of us who maybe haven't got that facility might need to get it.
I think one of the big things about autofluorescence is trying to differentiate inherited retinal diseases. And even in some of the seminal publications, there is pictures of inherited retinal disease as an example of geographic atrophy with hyperautofluorescence. So even the experts get it wrong. And so I think we have to, by demanding to have hyperautofluorescence to get into the study, they're inherently risking putting in people with Stargardt's disease. So it's just one thing.
That's true.
And so there are different patterns of hyperautofluorescence, but most people can't even read them. I can't always find out what they are compared to Holtz's original paper. But I think the trickling one is definitely it's probably a different disease, but it's certainly a very significant risk of growth. And I think they are stage 4 RPD, which is why it's such a high risk of progression. But there are certain patterns that are helpful, but they do bias completely who's in the studies, because they only allow people in with hyperautofluorescence. But
I'd sort of add to sort of just the discussion around autofluorescence in that we need to find a way of making it easy to use in our workflow. So we're going to not only just take the image, but then we've got to get parameter values. So we've got to measure the area. It takes a long time for clinicians to be doing that on their own and disrupts the workflow. The imaging companies are trying to help by giving various parameters to automatically measure some of these lesions. But I think the reality is that we'll be using types of algorithms that will be provided to us that will essentially take out the important parameters. So, for example, the GA area or some of these high-risk features that have been identified, there'll be algorithms that will help support us in that way. And I think that's why I think it's really important, some of the pilot work I was discussing. So with FRB, we've been linking essentially imaging to clinical data. And the reason that's important to do, we've been doing the initial pilots at Jenny Arnold's rooms and Mark Gillies' rooms. And the reason that's important is because once we can have that infrastructure in place, then we can potentially start offering that to scale that to clinicians across the country, and trying to take advantage of getting the algorithms basically to support our workflow, because otherwise it's going to be very laborious.
Also, autofluorescence images are not the easiest in the world to take, and a poor image is useless. So to start getting even your team used to taking them is not a bad. And patients don't like it because it's very bright.
Yes.
And so you don't want to do it. You don't want to do it all the time. But yeah, so no harm in starting to practice.
Oh, is that Tony up there? Yes.
Can I ask you to speculate on a gloomy note? Why do you think the treatment results were so modest? Do you think that we're unable to achieve adequate complement blockade? Do you think there is complement-independent mechanisms of growth of geographic atrophy? I know. Can I just ask you to speculate?
Yeah, complement's just one. It's not the cause of AMD, and so I think there'll be a limit. There's just a upper limit that's going to work, no matter what treatment you use to block complement. I probably don't even think it's much to do with the cause. It's more to do perhaps with progression. So I think there will be an upper limit, but I agree. It's only one. It's a start. Absolutely, we have nothing, and there are many patients that would grab, slowing down, losing vision for 1 or 2 years. Remembering that these people are usually a couple of years older than people with CMV, so they're already a bit older. But yes, it's just not the main story in what's causing AMD, I don't think.
No.
But Jenny?
Yeah, I agree, and it will. I mean, this is pretty intensive treatment regimen, and that's why it's so important to try and select people and understand better which people are maybe going to benefit the most and slow the most. And that's where what Derek was mentioning about biomarkers that might indicate that. But I agree with Robin. This is an aging disease, and it's been incredible that we've managed to find, something like the complement that is a predominant and influencer in what is a multi-risk disease. So I think it's crazy we've got something at all.
For example, so the reticular pseudodrusen are much more associated with HDRA1 gene rather than the complement factor gene. And so 40% of people with intermediate AMD have reticular pseudodrison, and by the time you get to GA, about 90% do. So, we're just missing an entire pathway that's got absolutely nothing to do with CFH and the complement genetic risk factors. So, maybe it'd be 3 injections in your eye.
Exactly. Well, unless there's any other questions, I think we're coming up to the end of the session. I thank everyone for getting up in the morning. I particularly thank our speakers, Robin, Derek and Hemel. Thank you very much.
Thank you, Deb.